have each one of you here to participate and take part in an interesting webinar on hemoglobinopathies, hemophilia, and thalassemia treatment practice and approach. The West Bengal edition, organized by ET Health World, the Economic Times Group, with Hematology Education and Research Trust as a knowledge partner powered by Takeda. As we are all braving the pandemic effect for the past 3 years, management of hemoglobinopathies during the COVID-19 pandemic is an important topic to be discussed. This evening, we have experts who will be discussing in detail about hemophilia and thalassemia, the blood-related disorders, and how managing hemoglobinopathies requires a complete ecosystem of management from administration to treatment. Today's event is the West Bengal edition and will comprise presentations and discussion on hemoglobinopathies, treatment practices and approach, wherein healthcare officials of the state will discuss the achievements in management of hemophilia and thalassemia and new approaches that are required to strengthen the program. We are honored to have each one of the health experts here who have joined us today. I once more extend a warm welcome to each one of you on behalf of ET Health World. Without further ado, I would like to call upon our first speaker for the evening, Dr. T.K. Dolai, Professor and Head Department of Hematology, NRS Medical College, Kolkata, to talk about a very important topic, bleed impact to bleed-free life, the West Bengal outcome. Over to you, Dr. Dolai.
Respected Devashish sir, DME and the ex-official secretary. So before I going to my session, I request Devashish sir, please say something for this our webinar. Devashish sir, please.
It is really great that all of us have joined in an important occasion, and quite naturally it is a challenging thing, and all of us should work together so that we can come to some platform where we can really be there by the side of the patients, and all of us should fight for it. Wish you all the best, and in the offering of the Bengali New Year's and also the New Year's of Vaishakhi and many of the other parts of the state, I wish all the best to all the panelists and also to our patients and their relatives. Thank you.
Yes, sir. Thank you very much, sir, for your kind work. So thank you very much for everybody, and good evening, and special thanks to our Devashish sir, DME, and give us the time to this program. So basically, the economics and the health, and also the patient and the parents' confidence for the treatment. This is our aim and goal to initiate in hemophilia and the thalassemia treatment. So my focus is the hemophilia treatment, the development of the hemophilia bleed model. Basically, in this model, my important aspect is that how we can cater the hemophilia treatment with a cost-effective way. So we have been working with the Vista Health, not only the me, but also the different key leaders. They have been working in their model, how we can develop a health model to give the delivery to the kind of our patients and the patient relative with a lower and the chief economic cost, without any compromising the quality of the life, without any compromising the deformity and the disability. So the Vista Health is basically taking the interview of the key leaders of the hemophilia across the India, and also they have been taking the interview of the key leaders into the West Bengal also, and they are developing the model how we can go ahead with the bleed-free model in the West Bengal. And idea is that it is cost-effective and economic also. There is a different aspects of this treatment of the hemophilia is there. You know, there is a on-demand therapy is there. There is a prophylaxis is there. In the prophylaxis also, there is a low-dose prophylaxis. There is intermediate prophylaxis, and the standard dose of the prophylaxis is there. So how we can implement it, and which doses is becomes economically safer and economically better for our country, and how our administration is helping to us with a lower budget and improving the care of the patients with the hemophilia. So this Vista Health basically the important thing is that to estimate the impact of the standard of care in the management of the hemophilia A, particularly in the non-individual settings. And this is basically we are predicting the outcome in the 1 year and the 5 years with a severity of the hemophilia, their ages, their annual bleed rates, and also the healthcare resource uses. And our output is that the total number of bleed by reducing the joint deformity, joint damage, and ultimately they are increasing to the productivity of the people with the hemophilia. How we can do that? So initially they have been giving a model that throughout the India that around the 6,341 hemophilia A patients, and they have been taking the interview to the key opinion leaders that working into hemophilia, and they have been taking the interview. The present scenario of the India is that if you consider the annual bleed rate, in terms of the less than 40 years, it is around the 20 in case of the severe hemophilia, and moderate it is 16. And if you consider the 14 to 18 years and the 19 to 45 years and older, so the incidence bleed is more or less similar, around the 20 bleeds is called annual bleeding rate while on the on-demand therapy. And in terms of this, the usage of the different regimen to control the bleeding of the severe hemophilia, there has a on-demand therapy, and the majority of the Indian people they are receiving the on-demand therapy. That is the 70% of the people on the severe hemophilia they are receiving the on-demand therapy. Only there is around 20 to 30% of the people they are receiving the some form of the prophylaxis, particularly in case of the Indian setting. There the majority of the center they have been giving the intermediate dose of prophylaxis of the standard or the short half-life of the factor. So this is the scenario that have been identified throughout the Indian context, and also not only to the Indian context but also the state-wise the key opinion leader they have been giving their opinion for treatment of the hemophilia. So if you jot down that in the treatment of the hemophilia, mainly in case of the severe hemophilia, our idea is that we are converting the severe hemophilia to the moderate hemophilia by giving the different treatment regimen, particularly the prophylaxis. In terms of the on-demand therapy, where there is a bleed, we have to treat the patients. And to prevent the bleed, we have to give prophylaxis. There is a very low dose prophylaxis. If we give 5 to 10 intravenous unit per kg 2 times a week, and there is a low dose prophylaxis called the 10 to 15 intravenous unit per kg 2 times a week, and also the intermediate dose prophylaxis for 25 to 15 to 25 units, and also there is a standard dose for 25 to 40, and also extended half-life product by the standard dose is the 40 to the 50 international unit per kg. So these are our treatment regimen. So I will be mainly focusing the low dose, intermediate dose, and the standard of the care for the treatment. How it is the cost-effective analysis. We've taken care of all the aspects of the hemophilia, particularly the annual joint bleed, the deformity, and the disability. So in this relative risk model, that how we can reduce the joint bleed. If we consider that in case of the different prophylaxis regimen, it reduces the joint bleed. If we consider the on-demand, I already mentioned there is 20 bleed per year, the annual bleed per year. And if you use this any of the prophylaxis, you are trying to reduce the number of bleed, called the particularly in case of the severe hemophilia. If we consider intermediate dose prophylaxis, there is 77% reductions of the joint bleed. In case of the very low dose, there is around the 69, and the low dose is 76% of the people we can able to reduce the joint bleed. So any form of the prophylaxis, they have a role to reduce by the joint bleed. The study have been clearly shown us, and also the key opinion leader they have been given interview that this is effective. And there is several authors they have been given their opinion. They are the right side of the column, the reference and the comments by the different authors. That yes, the some form of the prophylaxis is essential to prevent the joint bleed and to improve the quality of the life in people with the hemophilia. And if we consider that in case of the severe hemophilia into the right side of the panel, that what is the relative risk of the bleed? If you give the on-demand therapy, there is a 100% chance of the bleed is there. If we use the very low dose prophylaxis, the relative risk is 0.22, and the standard of care, it is low dose. Usually we prefer it is 0.32%, and in case of the intermediate, there is a 0.28% chance of relative bleed risk is there. So in terms of reducing the bleeding risk, some form of the prophylaxis has to be given, both only the severe and in case of the very severe hemophilia. If we consider the extended half-life product, there the relative risk is 0.01. So the extended half-life product, they have more chance of reductions of the joint bleed comparing to the short half-life factor in the people with the hemophilia. How we can develop in this state of this West Bengal, and this the model, they have been developed for identifying the different key leaders, not only to the doctor but also the social worker, the NGOs, and the administrator, economics. A lot of the people have been involved to make these projects. How we can develop the cost-effective treatment regimen in people with hemophilia. If we consider the 1,400 patients in India, in our West Bengal, there is severe is 1,160, there is 83% of the people, and out of that there is 64% into the children. If we consider our scenario also, there is 85% of the people, they have an on-demand therapy receiving, and there is 10% of the people, they have been receiving the low-dose prophylaxis, and there is intermediate has been receiving only the 5% of the prophylaxis. If you consider the annual bleed rate, it is on-demand therapy, it is usually 25. And also in case of the across the age group, if it is increasing, like the 14 to 18 years, there is 25 to 30 annual bleed in case of the on-demand therapy. So if we are switching from this on-demand therapy to the different prophylaxis, in case of the hemophilia, we are able to do that in case of 20% of the annual switch of the patient with severe hemophilia from the on-demand to the intermediate dose of the prophylaxis. What the impact of that? If we consider the impact of the 5-year impact, that 20%, if we switch from the on-demand to the intermediate dose of the prophylaxis, we are able to avoid, there is 24,497 bleed we can avoid it. And the expected cost saving is 119 million in the Indian currency. And also important thing is that the target joint avoided around 1.5K, and the additional clinical visit also we have been trying to reducing the 115.3K, and there is 2176 death can be avoided, and the hospitalization rate also can be avoided, and we are avoiding the approximately 102 disability. So this model have been developed in the state of West Bengal by taking the interview of that. So there is a different advantage of the prophylaxis compared to the on-demand therapy of the people with hemophilia. How it provided our impact, if you consider the further breakdowns of this thing, in terms of the 5-year resource impact practice changes, that if you consider the bleed-related events, in terms of the bleeding, the target joint, the surgery, hospitalization, the clinical visits, the missed day, and the death, if we consider the events, this is very, very important. There is the reductions of these events if you give the prophylaxis. If in the on-demand therapy, there is changes, there is no changes from the point of view of the patient's bleeding, target joint, and the surgery. So there is a definite risk reductions of the event by practice changes to the prophylaxis. If we consider the cost issue, that if you do the on-demand therapy, that there is how much cost is there. There is a 493 millions is there, and if we consider this the prophylaxis, it is the 96. And in terms of the indirect cost, it reduces from the 101 to the 25. And also, if you consider the total cost, it is 1,710 million, and it is basically the 153. So there is significant reduction of the cost is there if we consider the prophylaxis from the on-demand therapy. So if we consider this scenario, in case of the different regimens, from the on-demand to the intermediate, to the on-demand to the low dose, and to the very low dose, and also the extended half-life, how this will affect, This will also affect in terms of the bleed, the target joint bleed, and the risk. But if we consider the base cases comparing to the different prophylaxis, yes, there is a significant reductions of this event by the any of the prophylaxis. Either you use the low dose, the standard dose, or the very low dose of the prophylaxis, there is significant impact in terms of the different events. And not only that, if we consider the need impact in terms of the financial aspect, in terms of the hospitalization, there is significant reductions of these events is there. And economically, also it is becomes very much beneficial. If we consider the last column, that the net impact including the factor of the per patients with the hemophilia, it is 109K. And there is the reductions of this any point of time that it is 1.4 with the extended half, 33.4K, and there is a 29K reductions of this amount of the expenses of the patients and also into the government. So there is any form of the prophylaxis is becomes very much important in terms of the reductions of these practice changes. If we consider that there is a home-based therapy, what is the impact is there? If we consider the on-demand to the home-based therapy, there is 75%. If we consider that we can switch to the 75% of the cases with the home-based therapy, there is a significant reduction of the clinic visit. There is significant reductions of the cost, not only to the factor cost, but also the other factor becomes very important. If we consider the per patient cost, there is 109K without any home. If you do the 75% of home visit reductions, there is the extended half-life, short half-life, and the low doses and intermediate doses. There is significant reductions of the cost issue is there. So the home-based therapy is also one of the important aspects of the people with the hemophilia with the prophylaxis. So our aim is to be given to the home-based therapy, and ultimately we are reducing the cost of the treatment with the hemophilia from 109 to we can reduce this as low as the 20K per year consumptions of the patients with the hemophilia. But there is some limitations of this model is there, that the hemophilia burden arises from the undiagnosed people who are not included in this model. Hemophilia is a complex condition. This patient condition and relative risk might be there. There is a limited the real world scenario in the data in case of the moderate hemophilia patient because the majority is not in the prophylaxis. And also we need to take more inputs from the key opinion leader, not only from the West Bengal, the India, and also the Indian global literature. We have to incorporate more to the more themes. And also there is a clinical impact, clinical input of the key opinion leader becomes very essential. It becomes also varies from physician to physicians. So there is some limitation of this model of predicting the less economically burdens in the people with hemophilia. So the top line result that in India indicates that the overall decrease the cost of change of the treatment practice, not only to the factor but also the out of pocket expenses in the people with the hemophilia. And this model has been really beneficial that our practice has to be changed from the on-demand to the prophylaxis, and also if possible that the home-based therapy of the people with the hemophilia. So if we consider the different aspects of the treatment of the people with the hemophilia, this slide I have already shown you that there is a 85% patient on-demand therapy, there is only 15% in the prophylaxis, and there is a changes of the 20% switch from this on-demand to the prophylaxis. There is a significant reductions of the joint bleed. There is a 80 to 86%. There is permanent damage if we don't give the prophylaxis. And in terms of these reductions of the factor cost, there is a factor cost is 6.8 to the 7.5 and extended half-life is the 12. If we consider the lowest possible things, then we can able to use any of these factors, plasma derived, the recombinant, and the cryoprecipitate. So depending upon the availability of the factor, depending upon the cost issue of the factor, we can utilize our resources. So we have to calculate the per unit cost, how we can beneficial of the people with the hemophilia. Because we have to consider all the aspects of the treatment of the hemophilia, not only for the imaging therapy, but also the hospitalization cost, the length of the hospital stay, the duration of the bleed, there is a nurse and the other attendance cost, out of pocket expenses cost, and also the other aspect that if the patient has a major bleed, the impact is huge. If there is no major bleed, the impact is less. And also in terms of the surgery also, we are able to reduce the surgery also. If we consider giving the prophylaxis of the any of the doses, that if the patient requires the surgery, that the number of the surgery is less, particularly in case of the orthopedic surgery, the pseudotumor surgery, all surgery will be the less, and ultimately it will becomes cost effective. So if we consider into the different scenario, particularly in case of the annual bleeding reductions, that is the very, very important, that the annual cost for the management of the people with the hemophilia that becomes estimated is around the 163 million, that excluding the cost factor, because it's the out of pocket expenses. If we are able to reduce this number of bleed, that is 26,987, we can reduce the cost is there. So the annual cost there is 163 million unit, but we can able to reduce this in further, and we have been giving the prophylaxis in the people with the hemophilia. Then the next thing is that how it is possible into the different scenario. In case of the different scenario, particularly in case of the without the practice changes, then the accumulated cost over the 5 years becomes massive. It is the 594 million, because there is a 98,377 bleed is there. If we able to do this by the prophylaxis, by reducing the number of joint bleed, our cost will be the less, the potential disability will be the less. So it is 126 to the, there is a 412 disability is there. There is a 126 bleed death, we can in case of the 906 706 death in the people with the hemophilia. So without any practice changes, the cost issue is huge, disability is huge, hospitalization rate is more, death is more, but if we reduces it by the prophylaxis, it will be our reductions. And important thing is that if we change the scenario from the 20% to more, this impact will be also more. So we can able to reduce the number of the factor consumption, number of the pocket expenses price, and also we can able to reduce the disability and the death of the people with the hemophilia. So with this, the 20% changes of this, the practice from this the on demand to the any form of the prophylaxis, that in case of the 5-year period, if there is 20% of the people manage to the on demand where they switch to the intermediate dose of the prophylaxis, that the 24,000 bleed we can avoid it, and in average there is 17.5 bleed per patient, we can able to reduce it. We can able to reduce the death of 176 patients, and also the bleed we can avoid is around the 24,000 cases. So moving to the enhanced management, we can able to save up to the 94 million in the cost over the 5 years period. So there is significant reduction of the cost issue is there. That included the clinical visit cost, that included the imaging cost, hospitalization cost, and the other cost issue is there. So in case of the Indian scenario, that if it is from the 954 million unit, then we can reduce it to the 575 million in terms of the Indian currency. And another thing is that in terms of the additional factor cost, if we consider that, if we consider the cost factor and the other things, in case of the 25% of the changes of these things, that ultimately we can able to reduce it, the cost issue is also there. If we consider in the last column that the total cost of cares will becomes more in case of the on-demand therapy rather than the prophylaxis in the people with the hemophilia. So we have to need to move from the on-demand therapy to the prophylaxis. I already told you that this total cost will be reduces. The event it also become reducing by giving the prophylaxis treatments. In terms of the compliance and the cost effectiveness and the accuracy of the prophylaxis, this is also becomes very, very important, because this INR in the millions that depend on the different aspects. So this is the breakup of the cost, how it is possible for the reductions of the cost issue in the people with the hemophilia, and the model that find that there is a possible variations of this the compliance and also to the joint bleed and also the percentage of the switching bleed. If you increase the switching from 20% to 30% from the on-demand to prophylaxis, this cost burden becomes significantly reduces in people with the hemophilia. How it is possible by the different scenario, I will give you the example here that if we give the scenario in different from the in low dose, very low dose, the intermediate, and the extended half-life in the brief, I'll be and also in the home-based therapy, the scenario becomes very much exciting. In terms of this, the alternative to the on-demand to the prophylaxis, the scenario, different scenario, I already mentioned this slide, that there is a significant reduction of the impact of the cost from 109 to only the 1.4 million, and also in case of the low dose, there is 33.4 million, 33.k for the reductions of this the cost. So it will be concluded that from any prophylaxis it becomes effective in case of West Bengal scenario also, and also in terms of the home-based therapy also, there is a significant reduction of the cost from 109 to the 15.4, or there is a 20,000 K in people with the hemophilia. So in case of the low dose prophylaxis, if you do that, then we can able to reduce this 100 and the 17 millions price. We can reduce this by reducing the bleeding, by reducing the disability, by reducing the hospital visit and hospitalizations. And if we consider that in the scenario of the standard half-life prophylaxis, particularly in case of the 20% of the switch, in case of the low dose prophylaxis, in the low dose prophylaxis also there is a significant reductions of the cost is there. There is a 41.9 millions is there. In case of this, there is a very low dose prophylaxis, there is 103 million cost savings will be there. In case of this, the very low dose standard half-life prophylaxis, that there is significant reductions of the cost to 46.8 million unit. So if the people have the hemophilia, any of the prophylaxis, ultimately in the long run, not only into the 5 and into the 1 year, there is a significant reduction of the number of the uses of the factor, and ultimately we are saving the money. If we consider the extended half-life, the scenario 3, that there is a saving of the 154 millions amount. This amount we can reduce is by giving the extended half-life production, or by giving the prophylaxis with the joint deformity, death, and the hospitalizations. An important thing is that the cost important of the factor cost. If we consider the factor cost also, this consumption of the factor cost is also becomes very important, that comparing to the non-bleed state, now comparing to the on-demand, in case of this the prophylaxis, particularly the extended half-life of the prophylaxis also, there is significant reductions of the long-term cost is there. Though it is the short-term cost is very, very high, if we consider calculating over the time, factor and out-of-pocket expenses and the other things, it will becomes very much cost-effective. And if we consider the 75% home-based treatment, that there is also the saving of 138 millions in Indian currency by reducing the different aspects. If we consider the intermediate low dose of prophylaxis, in similar cases also, there is significant reductions of this the cost issue of there. In terms of this, the excluding the factor and the out of the pocket expenses by related to the bleeding event and all the traveling and all these things, in that cases also, there is 136 million, there is a reduction of the cost is there. So in the last, that the focus of the pediatric population, that bleed related cost savings is around the 68 million in Indian currency. There is the out of pocket expenses, there is involvement of the family, there is the loss of the wages of the family, and there is a travel, and all these things if we consider together, in that aspect also, we can able to reduce the number of the cost of the people with the hemophilia. So in conclusion, that in case of the people with the hemophilia, we have to switch from the on-demand to the prophylaxis. Any of the prophylaxis becomes beneficial, and further go ahead if we switch to the home-based therapy. into the long run, if we consider the 1 year, if we consider the 5 year, there are the economic considerations of our health budget and also our the total money we have been spent for treating the people with the hemophilia. There is a significant reductions of the cost. Roughly, we can reduce it the one third, even into the 50% of this cost. We can able to treat the people with the hemophilia in the long run by giving the prophylaxis in the low dose and ultimately by the home-based therapy. And ultimately, we can plan that by reducing the cost, we can able to cater the, all of the people with the hemophilia in the state of the West Bengal. With this, thank you very much for the patient hearing.
In sharing how practice change can be cost effective and can lead to better health outcomes. That was really indeed a deep insights which you had given. I would like to call upon our next speaker, Dr. Bipla Pendu Talukdar, State Blood Cell Coordinator, West Bengal, for the next presentation on NHM initiatives to strengthen hemoglobinopathies program in West Bengal. Over to you, Dr. Talukdar.
Basically, what is the NHM initiative to the strengthening the hemoglobinopathies program in the West Bengal? So first of all, overall the scenario, the thalassemia, hemophilia, and other diseases, the blood disorders like sickle cell anemia and other hemoglobinopathies. Basically, they are all are the common genetic disorder that are the chronic, life restricting, and they require the long and specialized treatment. Okay, and they causes the distress and the financial loss to the family, and are a great drain on the health resource of the country. And India, there are almost 42 million carriers of beta thalassemia, and around 1 to 1.5 million patients with thalassemia major. Among the thalassemia major, there is also the beta thalassemia and E beta thalassemia also, and about the 10,000 to 15,000 babies of the beta thalassemia major are born in each year. And and most of the beta thalassemia major and the transfusion dependent thalassemia in our West Bengal, there are another variety, that is the E beta thalassemia also. That E beta thalassemia occasionally acts as a beta, looks like beta major, and they are the transfusion, they are the transfusion dependent, also called, they are classified as a TDD, transfusion dependent thalassemia. And apart from that, in India, there is over the 70,000 patient of hemophilia A and B. And recently, in our study throughout the West Bengal, we screened the people for last 14 years. We got near about the 1,400 to 1,500 patients of thalassemia hemophilia patient. But I think this is basically the tip of the iceberg. Most of the patients still now unaware of the disease, and the family persons are unaware of the disease, and they are not properly screened. So that's why we have a plan for stringent screening for hemophilia as well as thalassemia. Now, this is the present scenario in our West Bengal. There is most of the, for life since 2007, we screened near about the 17 lakh people, and we got that's a thalassemia carrier detected near about the 15.7%, and number of thalassemia transfusion dependent thalassemia, that is such a 19,240, that is 1.15%, and non-transfusion dependent patient, that is a 25,491. And most of the non-transfusion dependent patient, they have either E disease or other type of thalassemia, other variant of the thalassemia. And number of sickles, just now we have discovered only the 851. That is also the basically the tip of the iceberg. We are unable to screen, unable to reach for every people. So that's why the number is less in number. But we have already the 12 districts of the West Bengal are identified that have the lots of the sickle cell anemia patients. And number of TDD infected with HIV, hepatitis B, and HCV, those are taking the blood transfusion, and that is near about 1,399 patients. That is among that patient, that is of the overall patient, that the 7.27% of the total the thalassemic patient are also already affected by either HIV or hepatitis B or hepatitis C. And number of hemophilia previously, the data is not updated. That is 1192, but recently we have found that is near around of 1400 to 1500 patients. So, so we have some roadmap for thalassemia and hemophilia, screening of the spouse of carrier. If the spouse is carrier, that is the mother is carrier for thalassemia. So we should identify whether the spouse is the husband is having the thalassemic gene or not. And voluntary screening facility for all. And second thing, there's the process of the online registration. Apart from the our government health facility, there's so many patients attending on our private sectors. So recently we have no data. Those are the treating taken the treatment from the private sectors. So we should have a data. We should have a common registration system that everyone can register for planning a management, for the budgetary allotment allocation, and the future planning. How can we control the disease? So that is very important for online registration. And voluntary blood donation at regular interval for most of the peoples. Those are the thalassemics. And for emergency situation, for hemophilic also, we should they should provide. We have just now we have the 34 tissue, and the location of the tissue is mentioned here, and the name of the tissues. The 34 tissue under the two nodal center. One nodal center is Medical College Hospital Kolkata, and another one is NRS Medical College Hospital. How to part of thalassemia? So it is not yet prevent the disease. We can for a single patient born of thalassemia is not only the social burden, is also a burden for the parents also. So to minimize this, we should plan such a way that there is no one single birth of thalassemia. And the screening of hemophilia. So that is very important. Recently, we have the 34 tissue having the facility for coagulation study. Another two will be functional soon. That is the Medinipur Medical College and the Jhargram. And two nodal center having the facility for factor assay. And if we our coagulation centers, the 34 tissue is run properly, and if they identify any abnormality of during the coagulation study, they send the sample, or they can send the patient to the two nodal center, and they can identify by the factor assay whether that patient having the hemophilia or not, or others any other bleeding disorder. So that is very important. And antenatal screening for pregnant women, and those are the career, that is very important to identify whether the if mother is the carrier for hemophilia. So there is a chances of the male child is nearly 50%. So male child having the chance nearly 100%. So male child, so if we identify the if antenatally whether the born is male child or male baby or female baby, so we can, in this way we can screening the baby for whether that baby having that gene, the hemophilic gene or not. So goals of transfusion, that is in this way, the maintenance of the red blood cell viability and function to ensure the sufficient transport of the oxygen. So during the transfusion, it is very important the survivability of the donor red cell. So uh, donor red cell viability is maintained only by the if the recipient having the less number of donor antigen related antibody. So that is important. So phenotype matched blood transfusion is the most correct one. Apart from the ABO blood grouping, there is more than 350 blood group antigen systems are there. And apart from the ABO, the most immunogenic is RH and KEL system. And RH and KEL system, there is a different the loci. There is a capital C gene, capital small c gene, capital E gene, and small e gene that can create a very big problem to the recipient. So if we transfuse the phenotype match and antigenic phenotype antigenic match transfusion to the recipient, that may be the helpful for the recipient, and the red cell survival will be increased. So and that can achieve the appropriate hemoglobin level also. Other, if we transfer repeated transfusion, there is a chance of the more chances of development of an antibody, and more antibody, there is more chance of the destruction of the donor RBC, and we can't reach the proper hemoglobin level to the recipient. And if we are not able to reach the hemoglobin level at the proper level, at the at that desired level, so there is so many complications are there. There is so many growth retardation will be there, and there is a chance of the various types of disease, the various types of problems due to by adverse events due to transfusion of the blood, and avoidance of the adverse reaction, including the transmission of infective agents. That is also, no blood is safe blood, because the blood is a good culture media. So each and every organism can grow very first within the blood. So just we as per WHO guideline, or WHO guideline, or the NACO guideline, we are only screened for the agents, microbial agents, that is HIV-1, HIV-2, hepatitis B, hepatitis C, malaria, and syphilis. But apart from that, so there is so many, or so many. Apart from that, there's so many microorganisms can grow very fast, and that can be harmful for the recipient. So the avoidance of unnecessary transfusion, and and the stringent screening of the blood from the donor is very much essential. So this is the goal of transfusion. And hemophilia management, in case of hemophilia management, expert group from the medical colleges, they are also tracking all the patient. They are reaching the patient, and they are visited all the tissues as per their uh, their recruitment, and concentrated factors for all. That is very much important. Our motto, and supply the cryoprecipitate for undiagnosed patient. If any patient is come to the hospital, and we are having the history of the bleeding, among if he or she is not yet diagnosed whether he or she is hemophilic or not, so we propose that just transfuse at a cryoprecipitate, because we have 87 blood banks, and apart from 87, we have only the 30 foot tissue. So we apart from the 87 blood bank, we have the 33 component separation unit. So each and every component separation unit have a facility for the preservation of the cryoprecipitate. So they can at least they can support by the cryoprecipitate to prevent the bleeding, to prevent the damage of the joint. So that is very important. Our motto, and continuous monitoring from the local tissues. And each and every, when the patient is come to the hospital or come to the tissue, the continuous monitoring by the local tissue, that is very important. And the referring the patient to the nodal center is also approachable by the members. Those are the working in the tissue. And provision for inhibitors management, that is also very important. And our main target is the disability limitation. If we minimize the disability, we can uh, uh, prevent the his the we can give him or her as a good social life. And then what red cell components were preferred? We always preferred for the hemophilic, that is the packed red blood cells. In additives, we can use the additives, that is the sagam we can use. And less than 15 days old RBC, our target to transfuse the patient. I am already said that is a phenotypically matched RBC is, and a leukodepleted RBC, that may enhance the red cell survivability. And buffy could reduce the RBC and worst RBC if those having some allergic reaction to due to the substances present within the plasma. And leukofiltered of RBC, those have those having some FNH, febrile non-hemolytic transfusion reactions. In that cases, we can use the leukofilter. leukofilter RBC. For hemophilic bleeders, availability of the drugs 24/7 at the hospital or emergency. We have the provision for that, for each and every tissue, having that facility to preserve the drugs at the emergency level, at the tissue level, and early diagnosis and management, that is very important for bleeder patient, and prevents the unnecessary mobility to the patient. That is very important. When a patient come to the hospital, and with some specialists are they're telling that whether that patient having the real bleeding or not, but is the one patient, those having the hemophilia like disease, they are very aware whether at the time of the bleeding. So that is called as aura. If the patient come to the hospital, so we first, and they without the any investigation, first we can transfuse the cryoprecipitate, or if the factors is available near to the hospital or within the store of the hospital, so that they can inject, they can infuse the that factor concentrate to prevent the mobility as well as the unnecessary prevent the happening of the bleeding to the patient, and provision for the counseling also, that is very important. The all times to counsel the patient to encourage his motivation, and decrease the social fear factors. So that is very important for each and everyone. Now the West Bengal government initiated during the pandemics, provide the facility for transportation. They have the facility for transportation from one patient, the hemophilic patient, not only the hemophilic, they also transport the thalassemia patient who need to transfusion. They carry the patient from the home to hospital. After transfusion, they they again they're transferred to his or her the home by our own the transportation system, and ensure the concentrated blood for all thalassemics. We provide the concentrated PRBC for all, and provision for vaccination for all, and initiate the home therapy for hemophilic patient at the time of pandemic. So last of all, the mission of West Bengal government: prevent the thalassemic birth, provide the drugs, chelation therapy, and ensure the quality of life in each and every individual, prevents the disability of hemophilics, provision for physiotherapy to decrease the disability, and we also try to ensure the socioeconomic rehabilitation of each and every hemophilic and the thalassemic patient, and improve the IEC from panchayat level. So last of all, this is about the banner for each and everyone: thalassemia and hemophilia জানুন ও সতর্ক হন, and as well as পুষ্টি নয় রক্ত পরীক্ষা করুন, and hemophilia একটি রক্তক্ষরণজনিত সমস্যা. And another thing, that is the we can donate the blood, রক্তদান করুন। রক্ত এক আশ্চর্য উপহার, যে দেয় তার কিছুই খরচ হয় না, কিন্তু যে পায় তার পুরো একটা জীবন পায়। That's all. Thank you.
Thank you, Dr. Talukdar, for thought-provoking session. It was indeed a pleasure having you, and the presentation was a very detailed one. Thanks for your time. Next, we have an interesting session. Any session on healthcare will not be complete if we don't talk about data. So the next session is on leveraging data from lead impact model for establishing treatment approach for better SOC in hemophilia patients by Dr. Gaurav Bahuguna, Medical Affairs, Takeda. Welcome, Dr. Gaurav.
Thank you, Dr. Talukdar. Thank you, Dr. Durai, for first of all, such an insightful session. I had a lot of learnings today. So before I begin, I'd just like to address the eminent guest speakers, respected seniors and dear colleagues. So good evening to everyone. I am Dr. Gaurav Bahuguna from Medical Affairs team of Takeda. I'm looking after the rare disease portfolio and immunology, and would like to first of all thank you all for giving me this opportunity to present the topic of today's discussion, that is leveraging data from bleed impact model for supporting a better standard of care in hemophilia patient. And before I go ahead, I'll again acknowledge that it's an absolute privilege to be in the company of such esteemed people. So before we go ahead into looking at the data that can be leveraged from and the common strategies which can come out from to have a bleed-free or a near zero bleed free model, what we need, I'll just briefly walk you through what the background of hemophilia is. We all know that, but just a refresher. We know that hemophilia is a rare chronic condition arising from deficiencies either from factor 8, which is known as hemophilia A, or factor 9, which is hemophilia B. Having said that, though rare, but it's one of the commonest form of inherited bleeding disorders, affecting around 1 out of every 10,000 newborn individuals. If we have to take this prevalence data into account, India accounts nearly has around 1.2 lakh patients with hemophilia. This is the burden which is only second to USA. Having said that, only 20,000 patients had been registered in the HFI portal. These has increased to the current report, which talks about around 22K patients. But it also means that there is a clear underdiagnosis of the patients that are happening, or misdiagnosis of the patients that is happening. Having said that, if you look at hemophilia management, there is no one-time cure for hemophilia, and the patients require regular access to periodic clotting factors. The current goal, as per the data we have, as per the guidelines we have, is to achieve a zero bleed or a near zero bleeds, which not only improves the joint health, but also the quality of life of the patients with hemophilia. And to do that, it requires an individualized, outcome-based, multidisciplinary care to maximize the efficacy and achieve better patient outcomes. So with that in mind, let me just present to you what is the current situation in India in terms of the factor usage. If you look at the World Hemophilia Federation report, the factor usage in India is still on a very low side compared to the developing, leave aside the developed nations, but also the developing nations. And it has there are multiple reasons to it. One of the common reasons is the fact that the most common mechanism of management of such patient is on demand or episodic treatment. Right. Though this data has improved from the previous report, but it's only minuscule. It's 0.05 only that usage that has increased. Now, if you look at the current state of affairs, most of the India, and I'm not talking about West Bengal, but I'm talking on India as a journal, the default management is the on-demand treatment. There are multiple factors associated with it. But if you look at, what is the impact of such management on patient outcomes and health-related outcomes, so there has been a study that has been conducted by Dr. Anita Kar and her colleagues. It's a multi-centric cross-sectional survey which looked into the disability of Indian patients. Around 148 Indian patients, hemophilic patients, were taken, and looked upon not only the disability, but also this study went on to look at the impact of access to factors on quality of life and other factors like socioeconomic development and employment, so on and so forth. And the results of this this study is quite alarming. Alarming. 6% of the patients were actually found to be disability free. Only 6%. That means 94% of the population had some sort of a disability or the other. 1/3 of the patients had to discontinue education, and most common reason ascribed to that was health related reasons. Again, circling back to the way the patients were being managed, that was on demand. And one interesting thing that study this also pointed out is that disability score was significantly associated or directly correlated to the excess of clotting factor concentrates at home, which means that if the excess of clotting factors was there, the disability score was low, and vice versa. This was also found out to be very significant in this. Now, moving on, while we have looked into the impact of the management, especially the on-demand management that is there in India, what are the possible solutions to it? And we can basis of the data, there are some certain solutions around it. Dr. Dhulai has talked in detail about it, but I'll just just brush through it. So it all starts with right treatment at the right time and at the right frequency. The central or paramount to is adoption of prophylaxis as the standard of care for hemophilia management. Now, there are different levels of, different types of prophylaxis. We have a standard dose prophylaxis, intermediate dose prophylaxis, low dose prophylaxis. But what makes sense for India is something on the lines of a very low dose or a low dose prophylaxis, considering the resource constrained country that we are in. And the other thing is the adoption of EHL or extended half-life products into clinical practice and the treatment protocols for prophylaxis. And I'll be talking about them as I go along with the presentation. So coming to the first strategic point or the tactics that we can have, let us first look at the impact of low dose and very low dose prophylaxis on the patients. Now, before I do dwell into that, let us first look at how this entire hypothesis was created. So it is well-known fact that early and regular prophylaxis in patients with hemophilia, it leads to decrease in hemarthrosis, it leads to better health and joint outcomes, it reduces the number of hospital visits, and possibly averts the need for surgery. So the inference that can be drawn, or the hypothesis that can be drawn from it, that in the long term, it is possible that it might mitigate the cost over the episodic treatment or on-demand treatment, taking into factor both the direct and indirect costs. Is this so? Yes. It has been proved successfully in many global trials that various levels of prophylaxis, whether standard dose prophylaxis or personalized dose prophylaxis, has had a better outcomes on patients' life. But when you talk about India, and I'll just be focusing on the low dose prophylaxis, does low dose prophylaxis has what it takes to answer all the queries? So yes, there are many studies that have happened in India, but due to paucity of time, I'll just harp on the two studies. One study by Dr. S.P. Verma et al., which was a randomized low-dose factor VIII prophylaxis in severe hemophilia patients. Around 29 patients were taken. The age group was around 1 to 10, and they were followed for 11.5 months. What is interesting to note, and they were given either a standard, on-demand or episodic treatment, or a low-dose prophylaxis, which is 10 international units per kg twice weekly. What is interesting to note that the patients who were put on prophylaxis not only showed better patient outcomes in terms of joint bleeds, the emergency visits, the absenteeism from school, but they also had a significant higher compliance rate of around 98%. Right. They also required less secondary interventions in terms of orthopedic surgeries or other sort of surgeries. And it was sort of concluded in this article, but in this study, that it is that low dose prophylaxis is not only efficacious, efficient, but also cost effective way of managing patients in resource constrained countries like India. The second evidence comes from a study by Dr. Debendu et al., which has been presented in one of the conferences. And he talks about very low dose prophylaxis in children with hemophilia. It's a rural experience. What is interesting to note that not only the low dose prophylaxis, as was seen in the study with Dr. S.P. Verma, has a better outcomes on the quality of life, on the efficacy endpoint, but it also led to a drastic reduction in the factor consumption. So it fell from 1235 international unit per kg per year and came right down to 821 international unit kg per year. In India, I believe that with the low dose prophylaxis has been adopted in few of the states, like West Bengal has been one of the pioneers in adopting the low dose prophylaxis, and the other states have also followed the suit, like Kerala, we have Gujarat, we have evidences from Punjab that are taking prophylaxis. What we need is the prophylaxis to be imbibed and integrated in the state-driven protocols for other states too, which are by which they can not only transfer the benefits across to the patients, but also to the government in terms of the clotting factor usage. Now, the other thing that I was talking about is the adoption of newer therapeutic agents like extended half-life in India. So do we have an evidence around it? Yes, there is an evidence coming from one of the long-acting injectable Eloctate, which is from Sanofi, and it came as a donation from World Hemophilia Federation. So this study has been done by Dr. Mandal, who is also there for today's discussion. So this was conducted in severe hemophilia children, and a low dose secondary or tertiary prophylaxis was initiated in them. And they were followed up for 1 year. When I say low dose prophylaxis, it was 10 international units per kg twice weekly. And the results were really encouraging. Not only did these patients who were earlier put on standard, on-demand prophylaxis, on-demand, then switched over to low dose prophylaxis with EHL, not only they showed a significant reduction in median annual joint bleed rate that by 85%, they also showed a significant decrease in the mean school absenteeism by 86%. To add to it, there was a significant reduction in the average annual consumption of clotting factors from 944.2 international units per kg per year to 1560.3 international units per kg, which further augments and supports the fact that we need to imbibe not only newer treatment agents, but also have low dose prophylaxis, at least low dose prophylaxis integrated in the standard of care for state. To move ahead, this also showed that the patients who were given low dose prophylaxis with extended half-life agents showed a significant improvement in joint health, which was evident through a massive reduction in the hemophilia joint health score. The mean hospitalization fell from 8.7 days to 1.1 day only. So with that, I come to another strategy or another tactic that we can have to, and this is something which augment the strategies that we have already discussed upon, and this is nothing but having home therapy, implementation of home therapy. So home therapy is a concept that has already been well established and has been in practice for many countries. We have most of the European countries are following home therapy. We have Australia, we have US who have home therapy or who are practicing home-based therapy. But before I go into the evidence from India, let me just walk you through what does home therapy actually do. So the basic thing that home therapy does is it allows immediate access to the clotting factor, which is necessary for optimal management of the patients, which results not only in improved patient outcomes, but also the health quality and the quality of life of the patient improves, and also it gives them a sense of independence, so that they do not have to come back and forth to the hospital to get infusions, and they can utilize that time for being more productive towards the society. In India, honestly speaking, there is a dearth of evidences. Only one pilot study that has been done in KEM Mumbai was able to generate some evidence around it. And the results have been encouraging. This went as a poster publication at World Federation of Hemophilia Congress. It was done in around 18 patients, and it shows very encouraging results in terms of reduction in annual joint bleed rate by 77% and reduction in school absenteeism by 80%. Coming to the one more strategy that we can look into, or one more thing, tactics that we can deploy, is adoption of comprehensive care for patients with hemophilia. And it's something of a need of an hour, which has also not only been implemented globally in many developed and developing countries, but it also sort of recommended in the guidelines for World Hemophilia Federation. It is nothing but having a multidisciplinary support to the patients, giving them a holistic treatment and giving them a holistic treatment and management so that they have a better patient outcomes. And I personally believe that as India progresses, as we move ahead in the hemophilia management, currently in India, while this is only limited only to the tertiary care centers, as we move ahead, more and more centers will be adopting comprehensive care and will be passing the benefit to the patient. So with that, just to conclude, the current goal of management of hemophilia is to achieve zero bleeds or near zero bleeds. The way central to achieving these zero bleeds is the need to have a secondary or tertiary level prophylaxis. In India, a low dose prophylaxis or a very low dose prophylaxis, considering the resource constraint, makes more sense. It has also been shown that not only these low dose and very low dose prophylaxis has been able to pass on the benefits to patient in terms of better patient outcomes, but also reduce the factor consumption. The other thing is the integration of newer molecules like extended half-life into treatment protocols have also seen to have improved the patient outcomes and reduce the factor consumption. And in India, I believe we will be seeing more EHL molecules coming in by September of this year. Last but not the least is the implementation of home-based therapy that has shown to have improvement in patient outcomes, but is still in the very incipient stages still in India. But as we move ahead, I believe more and more centers would be adopting home-based therapy. So with that, I'd like to thank you, everyone. And just would like to reassure that that Takeda stands united with patients and the healthcare providers in this fight against hemophilia. Thank you.
So moving to the next segment, we have a panel discussion on a very important topic, challenges in current practice of hemophilia management and need of the hour. So I am very happy to welcome all the esteemed speakers and panelists for the session. We have Dr. Debashish Bhattacharya, Director Medical Education, West Bengal. Thanks a lot, Dr. Debashish, for joining in. And we have Dr. Talukdar, State Blood Cell Coordinator, West Bengal. And we have Dr. Madhumita Nandi, Professor and HOD, Department of Pediatric, North Bengal Medical College. Thanks a lot, ma'am, for joining in. We have Mr. Ajay Royce, the Civil Society Representative. And we have Dr. D.K. Dolai, Professor and Head Department of Hematology, NRS Medical College, Kolkata, as a panelist. And for moderating this session, we have Dr. Prakash Mandal, Associate Professor, Department of Hematology, NRS Medical College. Over to you, Dr. Prakash. Looking forward for an exciting session.
Thank you, Madam Pratibha. Sir, good evening once again. And I am very happy and I am very proud. We all are, in fact, very proud and privileged and honored that our sir, Professor Debashish Bhattacharya, is there, who is Director of Medical Education, Government of West Bengal. And sir is there in spite of his very, very busy and hectic schedule. Thanks, Dr. Nandi, Dr. Dolai, and special thanks to Economic Times Health World team for nicely organizing this virtual platform work. So without much wasting time, because we are already late by 20 minutes, I feel. So I am going to my just a few seconds. Allow me, I am going to my presentation. Area we are going to discuss is, we have discussed a lot about hemophilia today, and also few areas like what is happening in West Bengal in hemoglobinopathies also in and different complications also related to blood therapy like HIV infection, hepatitis B infection, all this. So keeping all these things in mind, we are trying to discuss certain issues. There are many issues, but because of shortage of time, we may not be able to discuss all those things. So at least we are trying to highlight some of the challenges which may be hindrance to in current clinical practice of hemophilia management, and what is the need of the hour. So I already have introduced, and Madam Pratibha has already introduced our esteemed panelist. Conflict of interest, none from me or our panelist. So that what is the treatment goal? As of now, we have discussed, it is clear that probably we have to, better way is to prevent bleeding rather than giving a sort of injection factor 8 or 9 after a patient bleeds, and ultimately it will lead to chronic arthropathy, hemophilic arthropathy. So what happens, there is acute bleeding, so you are giving factors to stop the bleeding, but another option is there. You can stop this acute bleeding before any episode of bleed. You can give factors and you can stop or prevent this bleeding. The thing is that by giving factors or in the form of prophylaxis, you can prevent complications, but after bleed, if you give factors, you can't stop all these complications related to joint recurrent bleeds, arthropathy, or whatever it is. So another thing I am already highlighted very nicely by Dr. Gaurav. So expected PWH person with hemophilia in India is 1.3 lakhs. If that is so, what happens? Now the diagnosed cases are something like 23,000. So with a birth rate of like this, very, very small number of cases are diagnosed till date. That is the fact. This is not a very old scenario. Even in 2020, 2022, if you take the data, you may show it like 18%, 20%, not more than that. So why that is happening? That diagnosis rate is only 16 to 20% in India. And another interesting field, if you study, we have other studies. Thank you, Dr. Gaurav, for showing our data, published data for the pediatric population, but we also have other two publications with low dose prophylaxis in adult population on quality of life, and child population on secondary versus tertiary prophylaxis. Those are published data from our center only. So more than 15 years of age, 85% of PWH, they are severe. That is another interesting. Severe means they are crippled. Those severe cases, they are crippled by different kinds of joint deformities, etc. So now I am coming to our esteemed panelists, that basically why there is such a huge gap in diagnosis of hemophilia, or we can take it as some breaking up the total issue, like what do you think is the role of state and central government? So sir, should I if I come to you, sir, role of state health authorities in improving this diagnosis?
I think you people have already discussed what state government is already thinking and the way we are wanting to move. But before we go into the exact problem per se, few of the things requires to be addressed. That as I was also worked as a principal at NRS, where both of you are working. There we should see that more than 60% patients were having only iron deficiency anemia, overloading your OPD. So we should work on that areas so that the patients do not come to your hematology department, where you can concentrate more on the real hematology problems. So that area requires to be focused first to burden down your load of checking so that you can improve the quality of the patient care at the real units, which we have not yet addressed in this discussion, because you might not have thought that we should address that one first, which is a major bulk of anemia as a whole. And whenever there's an anemia, patient directly refers to the hematology department for other detailed workup. So those areas
Yes,
requires to be addressed first, so that you reduce your load of patients just simply attending hematology department. Other area is requires a mapping and registry to be formed of the hematological disorders, because what we are now working is mainly extrapolated data on which, truly speaking, we are giving our planning. So quite naturally, this requires to be addressed, that we should develop a registry for our real patients, so that this underdiagnosis will not happen in future. These are the two areas I should feel before planning for the detailing of it. I think I've just rolled down these two, so that we talk in different tunes also as we progress. I think we can go to the other panelists so that they can share their views.
thank you, sir. So really these two areas are very important to improve the whole thing, starting from diagnosis to management of hemophilia and other rare diseases, hematological disorders especially. And of course, the people working under government of West Bengal, all we are working, we have started the initiative to take care of all these registries and etc., so that actually the what is the burden and what group of patients they require more some attention. So I am coming to the second part, like how can patient advocacy group, like if I mention the role of HFI, Hemophilia Federation of India, I am coming straight away to HFI because Mr. Ajay Rai, he is associated with HFI for long, and he is as working as an NGO leader. He is working, I think, for last 25-30 years for the hemophilics. So, what is the role of these different patient advocacy groups, association, or societies? Mr. Rai, please.
First of all, I would like to thank the economist time for giving me the opportunity in this platform. And coming to the point, first of all, I want to say, to identify more and more hemophilia, awareness program must be there, not only in NRS Medical College and Medical College in West Bengal. It should be in the district level, subdivision level, block level also. And then for diagnosis, I requested Professor Bhatta is there and other government official also is there. Please try to include in any district hospital for the diagnosis part. At least diagnosis part is very much needed if it is not in any district hospital. Otherwise, what actually happened when you identify any new patient, I am telling my own experience, when you identify the suspected hemophilia, when the doctor referred to the chapter, we have a good chapter in this chapter. So when we requested, please go to the Antenatal Medical College or Medical College for the diagnosis, the patient mainly are not interested due to the financial burden. And also, they have to visit too many times. Not only the first day they will go and all over the test will be done in the same day. So that is a great problem. So I requested the government to please create facility at least one district hospital in every district. Otherwise, it's very difficult to diagnose. And secondly, I request to the government also, please provide the medicine, anti-hemolytic factor according to the requirement.
So, Mr. Rai, please, we will come to treatment part later. So, we will take your opinion in that part. So, I think what Sir Professor Bhattacharya and Dr. Talukdar also highlighted, that government is seriously working on the issues of extending the diagnostic supports and treatment facilities in. And by this time, all understand, those delegates who are present over there from different parts and corners of West Bengal, that earlier only these facilities was available only in two hospitals in Calcutta. Now government is seriously working on the issue of diagnostic as well as treatment in different tissues like thalassemia care units. So I will come to that. Now coming to another big challenge, like what is the per capita utilization or median global factor 8? This was studied on factor 8. So you can extrapolate this data for your factor 9 patients also. So the scenario in India was like that, 0.23, and one of the published data in 2021 by World Federation Hemophilia, this slight improvement like 0.31 only. So we belong to this area that per capita utilization of factor is like that, in spite of every effort of Government of India and all different state governments under NHM projects. So coming to our second part, like how can we improve the per capita utilization of factor, or how does the per capita factor consumption affect the life of PH, or do you think that per capita utilization of factor correlate with quality of life? I think Dr. Nondi or Dr. Dolai, anybody can take this question.
Okay, if I'm permitted, thank you. For the last 1.5 hours, we are listening to various aspects and what the government is doing, what are our efforts, and what actually more should be done. But this question that, as this very obviously per capita consumption of factors is very much related to quality of life, because more per capita consumption means better management of patients. So better management, if patients are better managed, then better, like they will have less number of bleeding, and the consequences, less amount of consequences of that bleeding, less amount of arthropathy. So naturally, quality of life will improve when the per capita consumption of coagulation factor improves. So we should make every effort. And one more thing, actually, the figures which are being quoted as the incidence of hemophilia in our setting is a dismal underestimate, I think, because if truly the incidence of hemophilia A is 1 per 5,000 male live births, then it cannot be it has to be something in many lakhs. So we have to have an idea about the true incidence of hemophilia before, like, we proceed further in how to manage patients with hemophilia.
Coming to Dr. Biplab, like what are the prospective measures? Talked much about on this issue already. Prospective measures to improve the per capita factor consumption or improve the quality of life among PWH.
First of all, the utilization factor, that is very important. For one of the factor concentrates for the each and every patient. That what type important in this on the point of view, the first, when a patient come to the hospital and the utilization with the factors, we have the two options, whether the patient comes to the emergency or come to the tissue. If the tissues runs throughout the week 24/7, not only 24/7, that is a 24/6 at the emergency level, and at the tissue level, that is runs by the 10/4. But when patient come, the bleedings not happen. Bleeding can happen anytime. So if the bleeding occurs at any time, so then the factors, providing the factors from the emergency level or the tissue level, and that's why we are not providing the all time. We are not providing the factors to each and every patient at the every moment. So and that's why we are not utilize the factors for each and every particular moment of time. So that may create a very difficult situation for the patient. So that's why that is improved that's made that may the patient may suffer from this that type of bleeders. They may suffer from the very difficulties, and there is some problems related to the bleeding, and that may related that may provide some deformity to the patient at that if the at the proper time, the right patient is not getting the factor concentrate. There's a more chance of the deformity and more chance of the hazards of the quality of life. So that's why the for per capita utilization of the factors is very important for us, for the not only benefit of the patient but for the benefit of is a benefit for the social also. So we try to put the factors at emergency level as well as in the basic level of the patient where the patient decides. We have some plan where the patient stay.
In terms of the factor consumption, I think the quality is very important and quantity is very important, because in factor hemophilia, the factor is very essential component. We need the adequate and the continuous supply. If we able to give it, even in the low dose prophylaxis, we can able to improve the quality of the life with reducing the cost. I think the factor supply is the very essential component of the treatment of the hemophilia.
Yes, so uninterrupted supply of factors, and that also the required volume and amount is very essential, as Dr. Nondi has rightly pointed out. Dr. Biplav also has pointed out. So I fully agree with Dr. Dolai also, that basically the prospective measures should be like from our perspective of view, that uninterrupted and continuous supply of factors in adequate amount. That is a big issue if we consider the budgetary section. So now I am coming to the next part. Like in severe cases, at least the factor level is almost at 0 level, and in moderate cases it is said that it is 1 to 5%, but in many cases it may be as low as less than 2% also. So we experience over years, we have seen the hematologists, the pediatricians especially, we have seen that some patient may have a factor level of 1.8%. So theoretically he is a moderate hemophilics, but his phenotypic behavior is like severe. So we always target to achieve a factor level by giving prophylaxis or therapy, whatever it is. So now we are coming to the next areas of challenges. Like what dose would you like to maintain? Like you would like to maintain the baseline or trough level of 1% only or 2% only? This is a big debated issue. Earlier WFH has recommendation of you keep it going to keep it up above 1%. Now the recent guideline says you may have to tailor it or individualize it. So I am coming to that issue, that Dr. Dolai, please, how to adopt the balanced guideline in this regard, like optimal dosing for bleed management.
So this is very important. The balanced guideline for treating the people with the hemophilia, this is very important. Means the international guideline is there. There is the World Federation Hemophilia guideline is there. The UK guideline is there. A lot of other society they have a guideline. But we have to have our own guideline in the Indian context, because we are in the developing country and there is financial is a problem. So I think in our Indian perspective, low consumption from the factor and ultimately reducing the morbidity and sometimes the disability of the people of the hemophilia, this is our main aim or main goal. So in India, we have to adopt our own policy by giving the low cost of the therapy, means the lower factor doses, and ultimately improving the quality of the life of the people with the hemophilia without any disability. So I think we may not copy paste the guideline of the Western countries. We have to have our own guideline
To come to the last question of this part, like considering the diverse topography, already our other panelists have highlighted some areas like terrain of different parts of states or countries, how to address the access challenge, access to therapy or continuous supply of factors in our state. Sir, please.
The thing is that 2-3 areas we can address that we should definitely have our own guidelines depending on our resources and also the mapping of the patients where do you have. In this area, we can utilize artificial intelligence also so that we can map it better. And also app-based what do you call it, directive systems where a peripheral center can have an advice from the consultant at the city, and utilizing telemedicine and others, we can definitely utilize our resources in a much better way. So even with a because it's a huge problem and requiring a lot of money, and but if we can plan it in a proper sense, reducing down basically in addressing the diagnostics at the periphery where we can cartel things uh, and make it a way that we can only address the mainly the hematologic disorders at the main center. And if we are sending the patients back to the peripheral areas where through telemedicine we can guide the peripheral doctors where we can make the reaching of the drug and the patient not to move much. Another area what we should think that preventing some gadgets or specifically gears in the knees, head and others, which to be developed where the kids when they are playing and others, they should, even if they fall, they don't get injury. So that areas of your guarding of the skull, guarding of the knees, guarding of the ankles, this type of devices requires to be built up. So that will reduce the injury of the joints, and hemostasis will be much reduced if the trauma can be reduced. So these are the different parts where we can work and can make our resources more useful for our patients.
So that is a very, very important information for all of us that we can develop one solve. So I think there is some problem. So we can make app-based access to the referral centers. So that is already, I think Takeda has 1 or 2 softwares based on this theme only. But I think we working on the government sector, we also have a good rich IT sector, so we can utilize that resource to develop these apps in near future. And I think Dr. Biplab can
we are already
take
with
this and help us in this aspect. So now, if we talk about the trough factor level, so earlier the concept was you just increase the trough level by 1%, 2% and keep your patient bleed free. But I am giving you some examples, right? Example like these 2 persons, they are working but a bit sedentary type of job. If you come to here, so young men, they are some very strenuous kind of job and work they are involved. So if you come to this very small child, so again there is every chance of trauma and more bleed. So you cannot equalize everything for every patient. So now that's why the concept of tailored medicine or patient centric approach of therapy, that should be or in simple word, you can say individualized therapy. It's not that it's flatly 50% increase for all patients. So you have to take the lifestyle that tomorrow the patient may have to get involved in school sports. So you may have to give a bit higher dose today in today's dose of prophylaxis. So these are the things we can discuss in different forums. So now coming to straight away, as it is established that prophylaxis is always and better option, better and better option, perhaps the best option if we compare it with on-demand therapy. But unlike, unfortunately, even in today in 2022, in many parts of India, on-demand therapy is the prevalent situation that is being practiced because of lack of access to the required amount of factors in time and continuous supply of factors. That is the fact. Keeping in mind that fact, I would come to the issue like what limits us in adoption of prophylaxis and what are the solutions. Dr. Dolai, please.
Talk to in that issue.
Okay.
That the adaptation of this, the prophylaxis, particularly in the Indian setting, the very low dose prophylaxis like 5 to 10 unit, at least the 10 to 15 international unit, this becomes sufficient enough in our patients. So at least if we can incorporate that in our day-to-day clinical practice from on-demand to prophylaxis with very low dose, we think we can able to prevent the disability and the deformity in the people with the hemophilia. And this is the not only responsible for our the doctors, but also our the administrator and our the stakeholder, the NGO, and also the patient support group, all should be involved and work together to improve the quality of care.
So thank you, Dr. Dolai. Coming to Mr. Ajay, that what would be the role of different stakeholders, like starting from patient advocacy group, like different NGOs, whatever it is. What is your key message on this issue of adoption of prophylaxis?
I fully agree with you and all the medical fraternity. The prophylaxis is the best treatment. But sorry to say you, only 2 or 3 hospitals are providing prophylaxis therapy. But every nowadays 34 medical college and hospitals AHF are free, and thanks to government for this. But only 3 or 4 available due to lack of awareness. They don't know what is prophylaxis. So I again request you that to please create more and more awareness. Otherwise, factor is available all of the medical hospital colleges, but they are not providing the prophylaxis. I talked to the authority, I talked to the in charge of the thalassemia and hemophilia center unit, but they are not interested. I don't know. I don't have any guideline how to start the prophylaxis. So my request on behalf of the Hemophilia Federation India, whenever factor is available, government is supporting us. So why it should not be continued in all the hospitals and colleges?
So, Mr. Rai, what you want to highlight is that availability of factor is an issue. But even if the factor is available, sometimes it happens that the patients severe with regular bleeders, they are not getting because of lack of awareness. So we all have to work together. Government officials, the caregivers, the patient advocacy groups, NGOs work together on this issue. We have to sit and discuss and generate awareness amongst ourselves only. It's not a special group, amongst ourselves to improve the situation. Now I'm coming to Dr. Nondi. If you please say a few words on this home-based therapy, as because you treat the small children, being a pediatrician working over last few years, many years. So do you feel home-based therapy will be a better option than the patients will come to hospital and take the injection?
Very much, because then patients would not have to move. That would be like all the stakeholders, the patient, the child, the child's family, it will be a less disturbance on the routine of family life and the child's life. So if it is done, it would not need a hospital admission, coming to for going to a far off place for the therapy for once in a week or twice in a week. So that is there. And just one thing I want to mention, that till 1 year or so ago, I was in NRS Medical College. So NRS, the situation in NRS is much better than what I'm looking at in North Bengal Medical College. So regarding availability and regarding expertise, actually expertise and all, as Professor Bhattacharya has pointed out, even without any streamlined app-based, we always get, we can always consult, we have consulted Dr. Rajiv there whenever we face any problem regarding, but sometimes availability of factors and all those factor bypass agents which were easily available in NRS.
Dr. Nandi,
Yes.
sorry to. So basically, we will come to that part. We are discussing about the home-based therapy, and so what you have highlighted, that home-based therapy definitely will
Is better.
increase
Is
the compliance amongst patients, family members, and what I have highlighted in the last point, that it will indirect cost, financial toxicity, and of course, what we have shown in our studies in pediatric age group, that you can minimize the school absenteeism. There is a remarkable minimization of school absenteeism, annualized bleed rate, hospitalizations, loss of weight. Each day patient is coming to hospital with parents. So there is loss of wages, daily wages labor. It's a big issue. Even if he is not a, or mother is not a daily wages labor. So 2 days in a week, 3 days a week. So these restricts us in implementation of the successful prophylaxis program. So in that case, I think, and I hope, I expect that all of us will agree on this theme, that home-based therapy is far better than hospital-based prophylaxis. All we know, because of lack of time, I am not reading each and every word, that prophylaxis therapy helps in prevent bleeding, quality of life improve, and saves adjunctive therapy cost like hospitalization, etc. And if we keep both, so prophylaxis is always a better choice and option. What World Federation of Hemophilia, they have already highlighted this issue, that if you want to prevent bleed and if you want to prevent joint destruction, so you have to go for prophylaxis. Undoubtedly, this is this is proven beyond doubt. So this is the latest protocol. You all know. Still, I have pointed out here the World Federation Hemophilia latest guideline regarding different kind of, it was not there in the this low dose prophylaxis, this was not there in the earlier guidelines. So this is an established fact, and we are very proud to say that we are one group working at NRS over last 4-5 years who are working on this very low dose prophylaxis, and we have at least 3 published data now, and another 2 we are going to publish in very recent future. So now coming to another issue, like if you discuss about the, because I am coming to this issue because at certain point of time, Dr. Biplov highlighted over the issue of utilization of cryoprecipitate. But the problem with cryoprecipitate, Dr. Biplov, I say that you cannot solve every issue with cryoprecipitate. Your patient is diagnosed with hemophilia A, so you solve your issue if factor is not ready available in your hand. But if your patient is suffering from hemophilia B, you cannot solve this with cryoprecipitate. That is one I am coming to you. FFP, even with plasma-derived fast factors, the issue of transmission, transmissible infection, as you already have highlighted, that hepatitis B, C, HIV, these things, they are the chance of, and nowadays we are much afraid of, if we can avoid with better kits, we can avoid these hepatitis B, C, etc. But we cannot get rid of prion disease, another big issue with TTI. So with recent advances and evolution in recombinant technology, the newer recombinant products have nearly replaced the plasma-derived factors in Europe, America, and many other developed or developing countries. And hope and I am very proud to say that fortunately we are also one center, and our state also we are getting free supply of these recombinant factors. Now, if you go to way back 90s or to 20, so you will see that there are a lot of patients suffering from HIV. Now, the last question is open to all panelists, that do you wish to give any message or to any message to various stakeholders on this aspect of this TTI, transmission, transmitted infection? First, I will come to Dr. Biplab. Yes.
Voice breakup and echoes. But recently in our trends,
The prevalence of
the
the
prevalence
HIV
of the
already
HIV already
decreases,
decreases,
and
and
for the
for
stringent
the
screening,
stringent
and as well
screening,
as
and as
we
well
are
as
using
we are
the
using
instruments. Previously, the most of the tests in the blood banks happened by the rapid test. After that, evolution is continuously going on, and you are using the ELISA. After this, we are using the CLI based test. So there is the chance of the most uh, false positivity, but the chance of false negativity is very less. So in this context, we can say, so we can confidently we can use, but there is very few chances of the transmission of the hepatitis HIV or hepatitis C, where and but there is a minimum chance. But in
But sir,
but
as
though we can use
but
the
sir, Dr. Biplab
cryoprecipitate
has
only in case
already,
of
okay.
hemophilia A, but in hemophilia B, we are unable to use the cryoprecipitate.
Yeah.
So
So
initial for
it cannot be a single solution for all hemophilics, as because hemophilia A and B both now, with the help of recombinant technology, we have the different. So we have gone far from those issues of like only. So if you see this, we started with plasma therapy only, then cryoprecipitate in 1965 or 70s. So now we are in the age of recombinant. We are using recombinant insulin because of all those things, plasma derived factors, etc. So now we are looking forward for gene therapy in hemophilia. So probably we have to make a sense that we will shift from plasma derived factors to recombinant factors, as because it is proven beyond doubt that recombinant factors chance of inhibitor development, it is already seen by different studies. So again in these recombinant factors, they are in different generations. These like Android phones. Now we are going for 5th generation. In here we are working on 3rd generation only. So all the factors, 3rd generation factors, are available in India also, and government of India and government of West Bengal also now purchasing this advert, that is a 3rd generation factor. So because of these different issues related to, and most important thing, the volume of administration, as Dr. Nandi will I think she will agree with me, that volume administration with plasma derived factors on an average is 5 to 10 ml. If you come to recombinant factors, the volume of ease of administration to a very small child, 1 year, 2 year child, you want to give prophylaxis for 2 days or 3 days in a week. So giving 5-10 ml 3 days in a week, it's a very tedious and very difficult job, because venous access is a big issue. So recombinant factors can solve that issue also, the issue of eliminating the different TTIs. So probably that is more advantageous than that. And as because we are running very late, I will request Sir Devasi sir to comment anything till this part. If yes, sir. Close
The
this session.
thing is very simple, that we should work together to aware the society, diagnose early, go for prophylaxis, and plan for home-based therapy. That will be our goal in future.
Yes, sir. So we are
and
running
reduction
short
of
of
the
time.
cost of the factors.
Yeah.
That is very also important. The reduction of the cost of the factors, that is also very important. But
No, that we
can
we can discuss. This is a scientific forum. I think we can sit with the commercial masters who are actually mastering in this area, working on this
So
area.
if the use if the use of factors increase
Yes,
to like
yes,
to an
yes,
optimal level, the cost
yes,
will also come
yes.
down.
Over
The
years,
cost
it is
is
seen
bound to come
in
down.
India. 5 years back, the cost was 35 rupees per unit. Now the government of India is purchasing it at the cost of 10, 13 rupees unit per unit cost. So it is possible. So I will
Exactly.
close if no objection from any of the panelists. And if all they agree that I should close in time, I am already late probably. So the best way to get started is to quit talking. So I must quit talking and we must begin doing as Sir, Professor DME sir has highlighted. We must sit together and work together to address these challenges one by one, and we should work together for the better care of the hemophilics. Thank you.
Before we wrap, we have a few questions from the panelists itself. We had a lot of other questions, but we have truly passed our time. So I'm just quickly taking two or three questions before we wrap. I would like to, ask the question which Ms. Madhumita Nandi had given to everyone. Will transfusion of cryo to undiagnosed patients be ethical? Cryo also has its own share of adverse effects. That's what she had pointed. I would like to know which one of the panelists would be answering this. Please keep it short. Who would like to take it?
I think Dr. Dolai is there.
Yeah, please, Dr. Dolai, if you can just.
Hey, I think as Dr. Prakash is highlighted in terms of the
Yes,
cryoprecipitate
that has been.
and all these things, I think this is the past of this treatment of the hemophilia. We have to go ahead with this recombinant factor and with a low cost, low doses, and reduces the deformity and the disability. So there's a lot of disadvantage of these blood products. So we have to go ahead with the recombinant factor with the low doses. This is my message.
There was also another question from the audience. Is there a standard questionnaire which can be given to the adult patients or to the caretaker of pediatric patients who are on home care prophylaxis factor replacement? Over to the panelist who would like to take this.
So I can take this question. The
Yes,
simple
Dr.
answer is it doesn't matter whether the patient is a child or an adult. The dose is actually fixed as per the per kg requirement, and that is also now being tailored or individualized, depending on the lifestyle and what kind of job the patient is involved. So that is the thing. And another thing is, if prophylaxis is available in your center, in your nearest hemophilia treatment center, what we call HTC, nowadays the TCUs, thalassemia care units, are also functioning as HTCs. Already Dr. Biplav had highlighted 24 centers are allotted fund for this purpose, and we all have to work together and make or generate awareness amongst ourselves so that they can start functioning for the patients to provide prophylaxis.
Can home-based therapy reduce the cost of government expenditure was one of the questions. So Dr. Adulai, if you can just answer it briefly, please.
I think I've been totally highlighted this, the home-based therapy and the low dose factor and our model, the Vista Health model, they have been beautifully shown us how we can reduce the cost. So at least by the home-based therapy, actually we reduces the cost of the treatment of the hemophilia. If we consider that at least there's a 50 to 70% people they are engaged with the home-based therapy, so the significant, that is 1/3 of the cost we can do the treatment with hemophilia. So on-demand therapy, with the low-dose prophylaxis, home-based therapy, the cost will be 1/3.
Is there really any robust data regarding the exact disease load in our country or in our state? I think there was a presentation on data. The figures quoted often are probably an underestimate. Do we need studies to seriously look into the exact disease load? Is the question. If anyone of the panelists
that can be solved. That can be solved by the adequate and proper diagnosis, as Mr. Ajay Rai has highlighted. If the facilities are available even in the district hospitals also. Now in present scenario, West Bengal has almost every district has a medical college. So if the facilities for PT, APTT is available and you can suspect that your patient is suffering, maybe suffering from hemophilia or some rare bleeding disorder, then they can be referred to any of the higher centers, and the thing will be solved much on a better way. So I think
No, it,
now the government is working on that issue, that each and every
uh,
medical college will be working. Unfortunately, of the track, I can say that even today, 10% of medical colleges in India have the facilities for hemophilia diagnosis. So if we
no,
can
actually
increase
that is
that
true.
facilities, yeah, Dr. Biplab.
That is true. Most of the patient, the toddlers are comes first after traumatic injury. They comes to either the pediatrician or either the orthopedics. So the pediatrician and orthopedics are not properly aware about this the hemophilia. So that if they're aware properly, they can send the patient to the nearest tissue, and after the at minimum the coagulation study, that is the PT epidemic, what the Dr. Prakash said already said. So if they perform properly the PT APDT after that and after the correction study, if there is any abnormalities, then they can send the patient to the true nodal center. Then we can diagnose properly. Well, most of the patients are missing, and when they come first to the orthopedician and pediatrician, they unlikely they are probably delayed the diagnosis. After the delayed diagnosis, can we can lose the patients also, and our the screening data is not properly fulfilled. So that's why we are also try to involve the pediatrician and the orthopedician. For the those patients have the traumatic injury, the bleeding disorder, they come first to the tissue. Just now we have the 34 tissue, and two is another upcoming tissue, and we are already one is the pipeline, that is the that is the Maniktola hospital, that is also in near future that will be the established as a tissue. So we have 37 tissue. So if we are working together and we motivate the peoples, and IEC, the information education and communication properly, we have if we done properly, then I think we have a very good pool of the patient, and the screening will be stringent, and then we can identify each and every individual.
Dr. Talukdar, and I have only those questions. We have more questions, but I think we have run out of our time. So a heartfelt thanks to all the speakers and panelists. You were like really patient, and the delegates for your participation in the webinar. Your participation helped in making the session and the panel discussion more engaging and interactive. Thanks for adding value to the event with your knowledge, experience, and enthusiasm. Thanks to our knowledge partner, Hematology Education and Research Trust, who has joined with us to organize the webinar on a very pertinent topic. We appreciate all our delegates for taking time off their busy schedules to attend this webinar. We look forward to your feedback and support on how we can make our webinars and sessions in life science segment more informative and meaningful for all our stakeholders. Thank you once again. Thank you.